Hello, CAM followers. It's lovely to be back and with a very lovely guest who you probably have met before. This is the lovely Dr. Matt Gurney, who is here for 45 minutes tonight, guys. So we really do need to, if you've got questions, please put them in and we'll do the best we can to answer them. So tonight we're talking quite a provocative topic. And the title is just that, because we want you to think. We want you to really start stepping outside the normal box and look at the medications that your vet is prescribing and try and think about whether actually they're not bad. So the topic is the perfect medication. And Matt's going to lead, but I'm going to first say thank you to our sponsors. So we are really lucky to be supported by Big Barker Beds, and I truly mean this from the heart. I met Eric Shannon, the founder of Big Barker Beds, many years ago, and he's been really supportive of CAM ever since. So when he stepped forward and said, "Hey, do you want us to support you for a year?" I was like, yes. And it really fits within CAM principles because it is a mattress that they've actually put through a clinical trial. So it was a pilot study at the University of Pennsylvania. I saw the receipt. It cost them a fortune to try and get some evidence behind the statement of can lifestyle modifications such as this bed have an impact on your dog's level of comfort and quality of life. And the findings in the pilot study were positive. So that is great news. So thank you, Big Barker. We're really grateful for your support. Right, Matt, introduce yourself. Let everybody realise how amazing you are.
Hello, my name is Matt. I'm a pain specialist. I work at Anderson Moore's Vet Specialists, which is a private referral centre in Hampshire in the UK. And I'm originally an anaesthetist by trade, and I became interested in pain management. So pain management in the hospital and at home. So dealing with chronic pain. Most of our cases are arthritis. We also see the weird and wonderful as well. Yeah, on a daily basis, I deal with pain management in a hospital setting and within the pain clinic setting. So I see clients from across the south of England and try my best to ensure that those pets, dogs and cats, are as comfortable as possible for as long as possible.
And you're also an educator because you are a co-founder of Zero Pain Philosophy. So any veterinary professionals that are listening, it is an excellent site, guys. If you want to go and learn more, but learn in nice packets. So I access Zero Pain when I'm driving. I've got it on in the background. If I'm doing anything that I can have some earphones in and you can just listen to it. It's really excellent quality. Yes, perfect, guys. Thank you so much for telling us where you're from. So please do keep putting packets of love in the chat, and if you've got any questions, get them in there. But Matt, you actually chose this title.
Yeah.
So why did you choose this title?
I guess I just wanted to get people thinking about, if you could, what does your ideal drug look like? It's actually a question that we always used to ask to students. When I was training at Liverpool as a resident, we have students coming through the anaesthesia service, and we say to them, right, what's your ideal drug? So if we actually said, okay, I have a dog with arthritis, what is my ideal drug? What do you want? What do I want as a vet professional? What do you want as a pet owner? Just throw a few thoughts out there, and maybe that'll lead us to recognize some of the things we've got and how kind of maybe close to perfection some of the things we've got already are. We talk a lot about multimodal therapy, so recognizing that we don't have one perfect drug in one capsule or injection. We do tend to use different drugs, and that's actually a good thing. Some people see multiple drugs as a scary or a worrying thing, but the reason we use those multiple drugs is because they act on different areas of the pain pathway. The pain system's so complex. Mm-hmm. So actually, one drug can't really deal right across that. And yeah, maybe should we dig into that a little bit, actually? That'd be fun.
Yeah, go for it.
So if we think about pain, let's say you've got a dog with elbow arthritis. So it hurts in the elbow. Where does that start? That starts with pain receptors, and those are on the end of nerves, and we call them nociceptors. Now, nociceptors respond to different stimuli. So typically in arthritis, it's an inflammatory disease. think of the joint as being on fire. That change in the joint is down to changes in inflammatory mediators. So essentially chemicals. They're chemicals that are produced when we have damage to the body. Those act on those nerve fibers, the little sensory endings, the nociceptors, to activate the nerve. And that causes traffic in that nerve from the elbow that goes up to the spinal cord. So that's the next junction, if you like, with that nerve going right from the elbow up into the spinal cord. If we're doing surgery and anesthesia, we often think about how we can target nerves along their path, and we'll do nerve blocks. And I'm sure a lot of you, if you've been to hospital and you've had a procedure, you may well have had a local anaesthetic used. I had one yesterday morning. I had to have a filling replaced in my tooth. So I had a local anaesthetic. I didn't feel anything when the dentist was drilling. We do that in dogs in the hospital if they're having surgery. We don't tend to do that on an outpatient basis because it's not terribly practical. Local anaesthetic doesn't last very long. We need to have the dog sedated or anaesthetised. So not practical, but useful when we understand the pain transmission pathway. That junction at the level of the spinal cord, it's not just a kind of A to B system. So the nerve synapses at the level of the spinal cord, and then that pain signal ascends up the spinal cord to the brain, where when we're awake and conscious, we perceive that as pain. So pain, we talk about pain being a conscious perception. And so there are various levels that we need to target that pathway. So at the level of the joint, practically we can't really do much to block the nerve, but we can use some drugs that act at the level of the spinal cord, and we can also use drugs that affect the brain and change the way we feel about pain. So there are a whole load of options available to us that target those multiple areas, and it's probably fairly easy to say that no one drug targets all those multiple areas, hence the reason for a multimodal approach.
Amazing. Perfectly put. And I think that's a really good way for owners when you're talking to your vet and they're starting to introduce multiple medications. It's a good way to kind of get your head around why they're on different drugs, because it is quite worrying, you know, when you've got multiple drugs going into your dog's body, like why can't we just have one? And I think we are led to believe that, in that we're all used to dropping paracetamols and ibuprofens, and it's a one pill wonder, isn't it? But it is much more complex than that. So going back to this like perfect pain medication, what are we trying to achieve? Having just talked about the pain pathway, are we trying to find a medication that can work in multiple zones?
I guess at the end of the day, what are we trying to do? We are trying to deal with the pain, and we're trying to deal with the suffering associated with the pain. Because if you're painful and it affects you on a day-to-day basis, which that definitely happens with our dogs with arthritis, there is suffering involved there. And like we say, no one drug can treat all of that. In the early stages of arthritis, yes, one drug can do a lot to reduce inflammation in the joint and resolve lameness, so our dogs can do all of the normal things that they want to do. As that arthritis progresses, because of those changes, let's go back to the elbow example, because of the changes in the elbow, that pain system is active constantly. So those nerve fibers, those nociceptors are constantly activated because of the inflammation. There's traffic in those nerves. That's like a motorway for pain going up to the brain. There's traffic there. At the level of the spinal cord, we'd naturally think it makes sense for the body to damp down any incoming pain stimulus in a chronic setting. Okay, pain is useful in an acute setting. It stops us burning ourselves, things like that. But long-term, pain doesn't actually have a useful role. The body does have its own system which can be activated. We always talk about pain inhibiting pain. So in response to a painful stimulus, the body does actually have its own coping mechanism. And actually that's one of the ways that acupuncture works, is triggering that system, triggering the release of endorphins. You've heard of endorphins. So we can actually damp down that signal coming in, but only to a point. So the body gets to the point where it just exhausts that damping down system. and then the pain gets transmitted up to the brain, and you're just told it hurts, it hurts.
It's like the floodgates open almost,
Yeah,
isn't it?
absolutely. Yeah, so these patients get to a stage where one drug can't control everything, hence we resort to different drugs acting at those different levels of the pain pathway. You know what
And
I
I
mean?
think that's
I mean that guy with the whiteboard that can draw.
you do.
We could have just done a whole pain system, couldn't we? We'll get
I
another
think
next time.
it gives us a really good opportunity to talk about a welfare aspect to managing OA, because we
Mm.
have a big client base that we're all being exposed to, and quite often we'll hear people saying, "Oh, he'll get used to it." You know, "Oh, it's just a bit of arthritis. He'll get used to it." I've had to get used to it. I have this a lot. Old gentlemen. Yeah, well, I've got arthritis. I've just got to get used to it, haven't I? And actually, that's probably a poor strategy when you're looking at long-term pain management. Imagining and encouraging them, just get used to it, habituate to it, learn to live with it, isn't actually good in the long run, because it creates a situation that's harder to manage later. And that's why all of you followers, there is a massive push in the industry at the moment, massive, to encourage people to identify arthritis earlier, so that we can implement really good strategies earlier, so that we have dogs that continue to use their limbs longer. They maintain their soft tissue structure that supports those joints, they maintain their function, they keep their quality of life, and they live for longer. But trying to get people to see the importance of approaching a limp, you know, something that's intermittent. Oh, I'm not sure it's really there. He doesn't do it every day. It can't be that bad. Is really, really difficult. Trying to step over that and go, no, now is when we need to act, because this is when we're going to really change the course of this disease. Is that fair to say?
Yeah, that's really fair to say. Before I answer that, I'm just going to say hi to Sian and her dog Heidi. She's one of my clients.
Yay!
Yeah, so when we talk about arthritis in the early stages, you've got that inflammation in the joint. The earlier we get in there, it's easier to control. I can't hand on my heart say this because we don't have the research over, say, 5, 7, 10 years, but I think a lot of vets would agree that the earlier we treat arthritis, the easier it is to control in the long run. It just makes sense that the more upfront we are about treating pain and managing pain, the easier it is in the long run. And actually, somebody's just made a really good point. I can't see your name, but it says that as an owner, understanding you had to acknowledge that your lifestyle meant that some drugs weren't being fully effective. I know we're talking about drugs, but let's just step back for a second. All of the management options are really, really important. So exercise management, physiotherapy, hydrotherapy. It's not just about the drugs. And to think that drugs will fix everything, that's sometimes actually giving drugs is the really easy thing. Doing the really hard yards is the exercise management, going to physio, going to hydro. All of those things definitely make a difference. And so, yeah, arthritis management is about all of those things, and not just drugs.
So, having introduced the 3 tiers of intervention, which I do exactly the same, I'm like, right, so we've got the local disease, we've got the modulation, and we've got the perception, and we can target drugs there. I also use that 3-tier system when I'm trying to get owners to not be scared of a multimodal approach. And I'll say, right, if I kick you in the knee, you're going to have pain in your knee, but it's localized. You still go home, you'll still drive your car, and you'll still cook yourself dinner. But if I keep kicking your knee, and the knee continues to ache for a few weeks, it starts to affect your capability, and it begins to affect your fun factor, and you don't play rugby and you don't hang out with your mates, and you start to feel like it's affecting your life. But then if it continues, it really isolates you and it starts to cause suffering. So we've almost got like 3 tiers there as well. So when I'm trying to get people to embrace that we're going to go in quite thorough, I kind of talk to them the fact that we've left just localized, and we're not even in just functional change. We're now, sadly, a bit in suffering. They're like, okay, what do we need to do about this? And that can work very well as well. So let's go back to this perfect medication. What drives your thoughts towards the perfect medication? We're not talking intervention, we're saying medication.
I guess if we wind back to all of the drugs that we use that have got a veterinary license, so if it's got a picture of a dog on the box, it should have a veterinary license. all of those drugs have been tested to make sure they work, they do what they say they're going to do, and that they're safe. So efficacy and safety are the two primary things we look at. The next thing we want to know as vets, if a new medication comes onto the market, is what's the compliance like? So can we administer this easy to the pet? Can the pet owner administer that on a day-to-day basis, on a weekly basis, on a monthly basis? Are we going to make sure that it's given at the correct frequency to get maximum benefit? Mm-hmm. And we know that from the studies, so we know how long that individual drug lasts. If it's given once a day, if it's given once a week, once a month, that's tested. That's where the dosing frequency comes from. So those are things we really want to know. Mm-hmm. We also want to know long-term, what the long-term safety is, because there's short-term safety and there's long-term safety, but often we probably don't get much beyond 6 to 9 months if we look at long-term safety studies. So I know a lot of dogs are on multiple medications for years. Arthritis is a chronic progressive disease. So really, once we start dogs on medication, we might start them at 6, 7 years of age, and they're still on them for the rest of their days.
Yeah, but I will put a little take-home message there as well, because a lot of people they'll stop themselves going to the vet because they're scared that they're going to be put on lifelong meds, and that creates terror, and it instantly makes them think that their dog's liver and kidneys are just going to self-combust, which they don't. I've never seen that happen. That they maybe the financial worry of a £50-60 a month ongoing is another reason to. There's multiple reasons that people choose not to go for fear of lifetime meds, but there are dogs that do reduce their medication requirement because the medication gives you an opportunity, a window of chance to lose the weight, exercise adaptations, lifestyle modifications. We might end up going for a more targeted approach, such as an intra-articular. We might use physiotherapy, shockwave. There's loads of other things that once they're in place, you actually go, do I need the medication as much now? No, I don't. I think we can come off of them. And I think that really needs to be discussed more, because there is a terrible belief that once you've got OA, once you see the vet, then you're on meds, that's it, done for life. Isn't there? That's a bit of an attitude.
I think someone's just put it in the chat really well. Cam educated me not to be scared of long-term medication. Yeah, I'm certainly not scared of long-term medication. I probably see the really difficult cases that all need long-term medication. So, but I guess if you're thinking, oh, hang on, I'm really worried about long-term medication, that just ramps up the importance of doing all of the other things, making sure the exercise management's there, thinking about physio. I can think of a 15-year-old crossbreed dog that sees me and our physio team, and since seeing the physios, he's got muscle strength back in his back legs. He used to have these little chicken legs. He's going to be such a happier dog, because remember that fragile joint that we talked about, if it doesn't have the muscle around it, it doesn't have a hope in actually trying to function normally. And then you see the dogs are quite wobbly because they don't have the muscular strength. And then they'll develop problems in other muscles because the muscles are compensating in a really abnormal way. So yeah, we think about things like physiotherapy for the benefits of the muscles in the immediate area. But what we need to remember is that bad muscle posture can cause knock-on effects in other muscles. You've heard of, let's say your dog's got trigger points. Those are really sore spots. And actually, if you've permanently got sore spots in your muscles, that definitely causes suffering. And to be honest, they're not very easy to treat with drugs. So physiotherapy and massage are absolutely the best thing for treating those trigger points. I bet you if everybody queued up right now for a trigger point exam with their dog, I'd have quite a lot. I love finding trigger points because they're so satisfying. It's a bit like when someone finds a trigger point in your back and they just rub it and you go, oh, that's amazing, don't stop. If we could have a queue around a car park somewhere of dogs where we find lots of trigger points and the line, maybe the next physio conference, we need to have a line of dogs.
You should do something about
trigger point treatment. Yeah, myofascial release is an amazing technique.
Yeah, no, definitely. So we will answer the question. There's some really good questions. I'm not ignoring you guys, I promise. But let's go back to these categories. We're talking about efficacy, we're talking about safety, and we're talking about availability and affordability. And I think these were like big categories that were in my mind of what do I need out of a medication. But let's start with efficacy. And I am being manipulative here, and I am pushing a bit of a veterinary evidence-based bias to here. But I just want people to understand what a medication has to go through to be considered effective. And the reason this is quite important is that, for example, placebo, you can see an up to a 30% improvement with a placebo medication. That's a dog having an inert substance being given to them, and the owner thinks it's a substance. They're giving it with that confidence, and veterinary professionals and the owners can see a marked improvement, be it due to a change in mindset and a belief, or due to something called regression to the mean, where the disease is naturally waxing and waning. 30%. So what does a medication have to achieve to actually achieve the title of efficacious?
It's quite a big ask, really. And for most of the veterinary medications we've got, you want to be looking at 20% above placebo. But that could still be fairly low. So we could have response rates of sort of 50%, which again, to me, seem quite low. I don't think I have to treat 10 dogs to see a response in 5 dogs.
Yeah.
That's, I guess, another way to put it. I think a lot of the drugs that we do have on the market are effective. I guess we've got to bear in mind those numbers come from studies where you've probably got about 250 dogs. The real test is when a drug gets released onto the open market and you have thousands and thousands and thousands of dogs using the drug. And I guess what's our measure of safety and efficacy there? That's the process of pharmacovigilance. So when a drug goes onto the market, if your dog is treated with it, and again, it's got to be a licensed medication, if that drug doesn't work for your dog, or if your dog has adverse effects with that, we need to report it back to the drug company, because they've got to understand what's going on with their drug. And I think in the first year, I think that's every 3 months, they have to report back to the European Medicines Agency. And then those periods extend out if there are no adverse reports. So I guess for a bit of reassurance, yes, we have the studies that are done in order to license the drug, but then there's follow-up work going on to track the incidence of side effects and treatment failures, if you like. And that's something that is looked at in all of the licensing studies as well. Actually, how many dogs in this group didn't respond to the treatment?
Yeah,
that's something we always want to look at.
And then I've had some owners make comments, oh, well, drug companies, they can afford to do bigger trials, can't they? And you're like, well, actually, no, because a lot of the situations of a clinical trial are very controlled. Dogs of a certain breed, a certain weight, a certain age, a certain disease. Is it unilimb lameness? Is it multiple limb lameness? Generally, in a drug trial, they would be excluded if they have another comorbidities. It's just going to confuse the picture. It's going to confuse the data. And they're desperately trying to get clarity of whether it's efficacious and acceptably safe. But when you put it into the cohort of animals that we see, you have different breeds, different ages, different weights. We've got some that might have hypothyroid, some that might have pancreatitis, some that might have IBD, some that might have something else. So these field trials are absolutely invaluable to really get real life data. And I think it's fair to say, because people are already asking about Librela, we are still very much collecting data to be able to make some really big statements. So I was teaching a group at Liverpool Uni today, and they said, so would you consider Librela as the foundation drug compared to non-steroidals? I was like, I don't know if we're there yet. You know, we're still collecting information about it. I don't know what's your thoughts of, is it on the same level?
Yeah, I mean, it's licensed for treatment as a first-line drug for arthritis. Yeah, so we don't have a head-to-head study. That's what we really need. We need a group of dogs treated with a non-steroidal anti-inflammatory compared to a group of dogs treated with Librela. We've got some, I guess, if we talk about what those studies are based on, those studies use, like you say, dogs that just have arthritis. So it's not dogs that have got other comorbidities, which is when you read the packet and it says don't use in heart disease, don't use in kidney disease, don't use in liver disease. That worries you. it's only because the drug companies haven't actually tested that use. And you'd find the same if you opened a pack of human medication as well. Thinking about working out, is that drug effective? They are using outcome measures that we use in clinical practice. So looking at pain scores, if I think of the 3 drugs licensed over the past 5 years for arthritis, they all use the canine brief pain inventory, which is something I use on a day-to-day basis with my clients.
Please, everybody, listen to that. It's absolutely impossible to get owners to buy into the importance of these questionnaires, but Dr. Matt Gurney, pain specialist, uses them on a daily basis. Please buy into the importance of them.
Canine brief pain inventory, low to Liverpool osteoarthritis in dogs. That's for what's the word? I've lost the word. Monitoring. Monitoring. Yes. And there's the Helsinki Chronic Pain Index as well, and one called Vetmetrica. So there are a number of pain scores out there. There's been a lot of work going into those. That's really important when we said you start with arthritis, but then it gets worse. And when does it get worse? And are you going to notice it getting worse? This is where we need the ongoing relationship with our veterinary surgeon or our veterinary nurses, whoever's running that arthritis clinic, doing regular pain scoring, working out when the pet is getting worse. And that could include what we call client-specific outcome measures, so behaviours that you associate with pain or your dog has stopped doing since they have become painful. Mm-hmm. I've just seen another one of my clients.
I know, you've got your fan club. Okay, so going back to this, the efficacy. Another thing I get a little bit bugged by is the speed of onset of efficacy. And I think that's something people really do overlook, in that there is something within us humans that we're drawn to natural. We're drawn to non-chemical. It's something deep in our heads. And the truth is, our interventions that have been trialed and tested are more likely to work more quickly than anything that we know in the nutraceutical world. Is that fair to say?
We don't have a huge... If you put the nutraceutical trials alongside the trials for current licensed drugs, I don't think there's really any comparison with how effective the licensed drugs are compared to nutraceuticals. I don't think nutraceuticals are a complete waste of time, and I think in early stages of arthritis, then there is potentially a benefit there. There are some studies looking at green-lipped muscle extracts, for example, but these, again, when we talk about the population of dogs, there'll be dogs with just arthritis, probably more mild cases. A nutraceutical isn't going to make much difference to a dog with severe elbow arthritis. But bear in mind, arthritis is a multi-joint disease. The dog may have other joints that aren't so severely affected, so you could argue that it's going to improve the quality of the joint fluid in those other joints. So I think a lot of it comes down to the fact that we don't have all of the answers. So you might hear me say something and someone else says, oh no, that's a complete load of rubbish. It's because we just don't have all the answers.
No.
I would love to be able to answer all of these research questions.
But would it be fair to say, if you had somebody come in to see you, they actually hadn't seen their first opinion practitioner, the dog was completely medication free, but came in and you pain scored them with moderate to severe musculoskeletal discomfort, where would you be putting your energy? In that, my mind is, I want to reduce this discomfort as quickly as possible. So when you're talking about efficacy, you're also in many ways saying, I want it to be efficacious, but promptly. It's not, I want it to be really effective in a month.
I guess I always think there are 3 first-line drug options as far as classes of drug goes. There are the non-steroidal anti-inflammatories, which are our traditional option. There are the PIPRANTs. Are we using names of drugs? To
be honest, I think it's fine, because you're not actually going, this is the one that I would support.
No, I'm just telling you what's out there. So the non-steroidals like meloxicam, carprofen, the piperant, grapiprant, the anti-nerve growth factor drugs, bed and vetmab. I've just used the generic names there for you. But there are those 3 options that we know are safe and effective for managing the pain of arthritis in the first instance. Now, I guess what we're wanting to do there is bring the pain under control, identify those trigger points, work on weight control, make sure our exercise modifications are all in the right place. We can then start talking about our pain behaviors. We can look at our pain scoring and just bring everything under control, step those pain levels down. So that's got to be our first aim, and work out that, yes, we have done something that's benefiting the dog to start with. And then we talk about all of the other things and where we go from there. So I think we've got to bring them under really good pain control to start with.
Yeah.
And see where we are. But yeah, let's not lose focus on all the other things. What we don't want to see is in 3 months' time, things aren't any better. Things might be worse from a pain point of view, but the dog's still doing lots of exercise and the dog's still overweight. So, and we've still got loads of trigger points and we haven't thought about physio. So, yeah, I don't think we want to be adding other drugs, until we've got a really good handle on all of the lifestyle factors.
Yeah, definitely. So now talking about safety, and then we'll jump over to talking about some of the questions. But this is a massive fear for people, and it would be good for you to kind of describe how adverse events are reported, like the accuracy, how clinical trials bring that data together, etc. Because there is a lot of bad press about medications. And it was only recently that I realized that actually the term adverse event is any negative event that was coincidental to being given at a medication. It doesn't necessarily mean a correlation. It's got a probable, possible, definite. So when an adverse event is reported, and say a drug has had 100 adverse events reported, they then get really filtered down as, is it possible? Is it unlikely? And I think a lot of people hear that term as well, and they go, oh, adverse event, I'm not going to touch it. And I was talking to an owner today about using non-steroidals. And I said, you really do have to understand that quite a lot of the GI upsets that we see in first opinion practice are probably coincidental. You know, the dog's picked up something in the park, they've picked up a virus, and unfortunately the non-steroidals, they're in place, and it might delay recovery, or it might just be there as a coincidence. So let's just spend a little bit of time talking about safety trials. What classifies as a drug as being safe enough to come to market? Because I think a lot of people go, they're terrible. Well, they can't be, because they wouldn't get to market. Is that fair to say?
Yeah, so if you were to, and bear in mind that these trials also have a placebo group. So we have a group that haven't got any drug at all. And so when we talked about efficacy, we're talking about efficacy above placebo. What we're looking at with our safety data is that the dogs in the treatment group aren't any worse off than the dogs in the placebo group. And that's really what the drug companies will use for the year after launch, if you like. When we're reporting adverse effects, they'll then go back through and say, well, did we actually see this in the placebo group? Could this be genuinely attributed to the drug rather than just a spontaneous event, if you like? Now, I guess bear in mind those dogs, if they are in a clinical trial and they're client-owned dogs, yes, they will go sniffing around the park and might eat something they shouldn't have done or pick something up from another dog. With the earliest studies in the lab dogs, they won't be scavenging or they'll be eating a very controlled diet. And I guess the other thing to bear in mind is the lab dogs probably have a very low incidence of inflammatory bowel disease, where I think when we roll a drug into a population of dogs, it's a surefire way to diagnose inflammatory bowel disease in a Labrador is give it a non-steroidal. And I think there's more inflammatory bowel disease in the general dog population than people actually realise.
Really?
Blame it on diet, but actually it's is the fact dogs have inflammatory bowel disease. It kind of just goes with the territory. So yeah, I personally think a lot of dogs do actually have quite a sensitive stomach.
Right.
Okay, that could be food related. It could be. It probably is related to some type of allergen from a diet point of view. That's just
unfortunately, then the medication gets demonized, and actually,
it's actually the individual.
Yeah, but I think it's fair to say that drugs don't come to market willy-nilly, and there is going to be a huge amount of work into making sure that the adverse event rate that is linked to that medication is actually pretty low. And if you ever did look at clinical papers and you look at the section that talks about adverse events, it is surprising how often the placebo or the control group, they've got vomiting and diarrhea left, right, and centre. They drop out because of kidney disease, drop out because of this. And you're like, crikey, that's just normal life, isn't it? Final little bit, affordability, availability. And I think this is really quick. And I love it when Gwen does this bit in lectures. So me and Gwen do vet school training and practice trainings. And people always go, so which non-steroidal or which drug? And Gwen quite happily will say that, well, we do not have any evidence that one is better than the other currently. So what we need to do is really think about is what drug is most likely to be given correctly. So if you know that you're a busy person, that you commute, you never get home at time because the trains are always delayed, having that 24-hour dosing ain't going to work for you. But maybe a weekly one where you can give the medication on a Saturday. Or it might even be that you want to give it monthly. Or it might be that you fight with the tablet and he always goes and spits it out back of the sofa. But liquid, winner. So I think what you also have to think about with this perfect medication is how available is it to you? How easy is it to administer? And the final logical one is that we've got to keep within your price point, to the best of our abilities. It's difficult being put on a medication that that you're not going to be able to afford long term. So do have that conversation with your vet. We're not going to think less of you. It doesn't mean that you don't love your pets. It really doesn't. But it does mean that we can start a management plan that's going to be more tailored to you. So we're going to use the last few minutes. There was a couple of questions. I'm going to go right back to the start, because this is one I just want to see how you answer this, because I know how I'd answer it. And I'm hoping this person, the Facebook user, has listened to us talking about inflammatory mediators within the joint and joint fluid changes and stuff, because this is a really big fear of owners that I've heard a lot when they're talking about bone-on-bone rubbing. But I've actually met spaniels that have got seriously grating joints. They're having the way all the time. It's not there. It's very much read the dog's pain state. So first of all, you need to know how painful that dog is, what their perception of their pain state is, and work towards that. Whereas I think our mechanical brains go, oh, we've got to fill the joint with some cushiony fluid and we've got to do this and the other. But I would definitely say get somebody to fully assess whether that bone-on-bone grating is actually a problem to that dog. Would you say the same?
Yeah, I mean, I'd say that is a case of a severely arthritic joint, and we need to do everything we can to protect the joint. So, yes, drugs absolutely play a role, but exercise modification, treating that as a really fragile joint, I would say, working out how it's affecting your dog on a day-to-day basis. So, thinking of those behaviours, what does he do when he's painful? What does he do when he's comfortable? How do we find that perfect balance? What makes a difference to him? Yeah.
And don't go away downhearted, Facebook user. I don't know your name, sadly. There is a trail of things that we can intervene with. So it might be that you start with a pain medication. It might be that adjuncts are added. You might be encouraged to control exercise, modify, weight, look at lifestyle. And then your vet might say, well, actually, your dog's overall pain state isn't too bad. We've controlled the myofascial pain. Perception's a lot better. But this joint is still very much a localized problem. This is where we might think about using something intra-articular. We might think about surgery. But it's almost like, as Matt said at the beginning, you need to kind of clear the fog. You need to deal with the overall and keep condensing it down. Peel the onion. That's it. Get back to where the core is. To a point question. Do you feel that you can answer this one?
We don't have any head-to-head. So Deramax is a non-steroidal, and Galliprant's Grapipant I mentioned before. Again, we don't have any head-to-head studies looking at which one is superior. I guess I think what I would say is if your dog is on a medication, try and work out in your head how effective you think that medication is. If you were going to switch for another one, what we want to do is we need a washout period between those. So you're going to end up with a few days, probably 3 days, where your dog's not going to be receiving either of those options. And then you've got to switch on to the next one and then give for long enough. So I'd say a month to work out whether one is better than another. You've got to have really clear outcome measures in your head that you're going to use to judge whether that is better than the other option. So I guess we have to think carefully about switching. What you might be thinking is, okay, my dog is on one drug and he seems to kind of plateau with comfort levels. Actually, at that stage, rather than take one away and add one in, I would add something different in on top of that original drug. So that's the multimodal approach, is saying, right, he's more painful than he was, he's on medication, probably because his arthritis is progressing, what do we add in next?
Perfect. Simply, what's your view in Librela at the moment?
I am seeing good results with the Librela, let's put it that way. I think it's very effective in mild to moderate cases of arthritis. I think it's less effective in severe cases, but I would say that for a lot of the drugs that we have at our disposal. So I guess, again, Librela is one of our first-line options. Non-steroidal Galliprant, Librela, we've got first-line options. We use a lot of Librela in conjunction with other drugs, which we end up having to do for severe arthritis. So yeah, I think what's really important there is understanding the severity of the arthritis when we're expecting what effects we can actually get from any drug.
Perfect. Another comment about this bone rubbing on bone and the fear. And I think this one really demonstrates to me the amount of fear that owners have of rocking the boat. And I'm just going to say, vets have it too. And I definitely know that when we've done practice trainings, vets on the other side of the table going, well, we're here and I could add this, but the last thing I want to do is make it worse. So you're not alone, Facebook user, on worrying that your intervention is not going to be the choice one for your dog. I'd say it's pretty rare that you're going to make things worse. And even if you have a little bit of a downturn, we can work very well to come up the other side. Steroid injections are used. They tend to be used more for like the end stage arthritis or for more the soft tissue kind of joints such as the shoulder. And what I've learned from others, from the likes of Matt Brunke and David Dicus, is if they don't respond to the first one, they're not likely to respond to a second steroid injection. Do you feel the same?
Yeah, I think we'd often say sometimes you do get a response to the first one, and then you think, right, okay, when do I do the next one? And then you do the next one, and you don't get the response. I'd say we sometimes see that with stem cells as well. They work initially really well, and then subsequently further down the line, they work less well. It's because the arthritis has progressed, and we're just dealing with much more difficult joints to bring under control.
I love it. And I love people's inputs, about all the things that they do. Well done, this person. It's really good. One of the things that CAM aims to do is enable you guys to learn vicariously from each other. We've always been aware as the vet profession that you do listen and talk to each other. You come out the vets and you go and have a chat with Mabel by the poo bin. What did they do with their dog? How did you get such good results? So this is fab. So please do tell stories. If you want to join a community that has this attitude, please do head over to Holly's Army. The community spirit there is absolutely insane. So you can go and share your stories there. Now, I'm watching poor old Matt flake because he's had a ridiculous day. So I think what I'm going to do is kind of like fold it up now. If you've got questions, please do put them in and I will do my best to come back to them later. Please tell me where you've been listening from, because we do this out of the kindness of our hearts. So having people say thank you is really like gold dust to us. So please do say thank you to Matt for giving up his time. He's been at work all day and he's given you his evening. And finally, I want to tell you guys, our new website has launched. Okay, it has taken so long to come together. It has cost Cam nearly 15 grand to get this website up and running. So please, please do go over and start using it. And there is a member zone there. So my dream many, many years ago was to remain financially independent so we could concentrate on you and giving you the best information possible. But to do that, we need to be financially independent. And the member zone is 25 quid for the year. For the year, okay? That is less than a consultation with your vet. All of that information for a year. And if you guys support us, if we had 100 sign-ups a month, we would not need to beg, steal and borrow to keep this going. We would be able to keep producing more and more and more content. So please do head over to the website and look at the member zone and think what a great deed you're doing. So thank you, Matt. I'm really grateful. We're back here on Thursday talking about pain and behavior. I'm really excited. But until then, all the thanks are coming in, Matt. They love you.
Oh,
head home, have a glass of wine. See you later, guys.
See you, everyone. Bye.